Basic life support. So the training aims. The basic life support course is designed to give care home staff basic emergency first aid and skills and knowledge. The course covers the following first aid situations: unconscious casualty who is not breathing, and unconscious casualty who is breathing, choking, casualty positioning, severe hemorrhage, also known as severe bleeding, and burns. Now, this presentation is for general information purposes and it does not replace professional practical resuscitation training. And the information in this presentation is taken from the Resuscitation Council guidelines on responding to choking, cardiac arrest, and unconscious casualties, and also in the first aid manual, which is published by the Red Cross, St John's Ambulance, and St Andrew's Ambulance. So those are the main references. And then also from my clinical experience in working in a care home setting to make those references more applicable to the setting. But staff should get practical professional first aid training. So this is really for knowledge. The learning outcomes: by the end of the course, participants will be able to understand the response to an unconscious casualty who is not breathing or breathing using the doctor's ABCD drill. They'll have an overview of the AED. They'll understand the response to a choking casualty. They'll understand appropriate casualty positioning. And they'll understand how to respond to severe hemorrhage and to burns. So before we actually talk about how to deal with an unresponsive casualty who's not breathing, we do need to talk about the do not attempt CPR forms. So DNA CPR. So if a service user has a DNA CPR form, it means that they are not to be resuscitated if they have a cardiac arrest. Now, cardiac arrest means that their heart has stopped beating. Now, if someone has a cardiac arrest, then the way that we can tell they've had a cardiac arrest is that their breathing will have stopped. So basically, this form means that we do not resuscitate people if they've had a cardiac arrest. Now, this form goes everywhere with the service user because an incident can happen anywhere. It only covers resuscitation in the event of a cardiac arrest. Other treatments must still go ahead. So if they're unresponsive but they are breathing normally, then we'll still call 999 for an ambulance and they'll receive treatment. An exception to a do not attempt CPR form is an unanticipated and easily reversible cause of cardiac arrest, such as suicide, choking, or anaphylaxis. So if those are the causes of the cardiac arrest and a service user has a do not attempt CPR form, then we still resuscitate them. So we need to check whether a resident has a DNA CPR form before we resuscitate them. Also, another preliminary is infection control. So you should always have an emergency pair of gloves in your pocket. These are not for your routine care tasks, but just for an emergency, just to be able to quickly put them on if you're going to deal with body fluids. They should preferably be nitrile, so that's the blue or purple gloves because they're stronger than the vinyl gloves. I'm going to discuss compression only CPR, but if you were to do rescue breaths, then you should use a pocket mask, as it creates a barrier from the body fluids when doing mouth to mouth. If any sharps are used during an emergency, then they should be immediately disposed of in a sharps bin at the point of care. Any dressings should be disposed of in an orange bin, and you should wash your hands after the incident. So the doctor's ABCD. So every single emergency, whenever you first walk into it, you should always start doing the doctor's ABCD. So this is whether you're dealing with someone who's fallen, an unconscious casualty, choking, burns, bleeding, anything, you always start with the doctor's ABCD. So the first thing to look at is danger, then response, and then shout, send signal for help, open the airway, breathing, call 999, start compressions, and defibrillation. So for an unconscious casualty who's not breathing, we would do this in its entirety. But if you're walking into, let's say, a casualty who's bleeding, and you come in and you look for the danger, you manage the danger, then you can see that they're responsive, then you not have to carry on down the whole algorithm. But this should always be done in its initially when you walk into any emergency. So when you come in, you assess for danger. So you're assessing danger to the casualty and surrounding environment, and for others who are potentially going to come in and assist you. Now, you only approach the casualty or intervene if you deem it safe and necessary to do so. So if you can see a danger that you can manage, then you'll manage the danger, you'll point it out to other people. If you cannot manage it yourself, you do not approach. You seek assistance, and you make sure that people know of the danger and they do not approach the casualty. And the casualty will be treated where they're found. The only reason you're going to move a casualty is if there's an ongoing danger to them, such as a fire. So dangers can include live electrical cables, broken glass, smoke, flames, trip hazards, etc. So you're going to have to identify dangers and decide whether you can manage them, or if you can't, you need to seek assistance. Now, once you know that it's safe, you need to then assess for response. So you can now approach the casualty because you know it's safe, and you're just going to do a simple shake and shout. And rather than shaking them, even though I say shaking, it's more of a push of the shoulders, and you shout in each ear, open your eyes. Now, if there's some response, if they open their eyes, if there's any groaning, talking, then they're responsive. Obviously, if they're standing up because it's a choking or a bleeding situation or a burn, then they are also responsive. The next thing, if they're not responsive, then you need to shout, send a signal for help. So you'll shout for help. You'll send someone to get help if they're with you. And if you're in a care home, you'll press the emergency call bell. Now, if the person is unresponsive, or is clearly it's very serious bleeding, at this point you can ask another person with you to call 999. But otherwise, you're going to wait for whoever comes to assist you to ask them to call 999. So the emergency call bell, so this is a typical call bell point in a care home. Now, if you press both of the buttons at the same time, so the darker button is the activating button and the lighter button is the cancelling button. If you press both at the same time, then that will activate the emergency call bell. Now, other staff, if they hear the emergency call bell, they should make the resident safe if they're with them, and they should walk to the location of the emergency. There should never ever be any running inside the care home. Now, if you really can't leave the service user because it's not safe, then you can have to stay with them. So it's not the same as the fire alarm, where you do have to attend the assembly point. Once you've sent or signaled for help, you need to open the airway. So you're not checking the airway, you're simply just opening the airway. So you'll do a head tilt chin lift, or if you suspect a spinal injury and you're trained, you can do the jaw thrust. But this is why you need to have practical training as well, so you understand how to do this, because this presentation is for the knowledge base behind it. So a check for foreign bodies would only be recommended by the Resus Council if the rescue breaths were proved difficult, if you were in fact doing rescue breaths. I'm only going to discuss compression only CPR here. But you open the airway, and then whilst you're holding the airway open, you're going to assess for breathing, and you do this for 10 seconds. a proper 10 seconds. You have to get close to the casualty's face and chest. So you need to look, listen and feel for normal breathing for 10 seconds. Now, if they're not breathing in that 10 seconds, then we assume that they're in a cardiac arrest, so their heart stopped beating. Now, also, someone who has a cardiac arrest, they can do something called agonal gasps or agonal breathing. And this will look unusual. It will not be a regular pattern. It will look strange to you. So if you see that, then that's agonal gasp or agonal breathing, and that is diagnostic that they're in cardiac arrest. Okay. And then also, if you're not sure, also just assume they're not breathing. So if they're not breathing normally, or you're not sure, from that point on, after the end of the 10 seconds, you tell everybody that they're not breathing. Okay. If they are breathing, though, if they are breathing normally when you do the 10-second assessment, then you need to put them in the recovery position and await for the other staff to come. So this is an image of the recovery position. So you're getting them on their side, and that's to maintain the patency of the airway, so to keep the airway open. And if they vomit, which is very likely if they're unconscious, the vomit will not block the airway. It will go out the side and onto the floor. Okay, so the recovery position maintains the airway and it keeps it clear from body secretions, vomit, etc. Now, again, in your practical training, you should be taught this and practice this. So that is if they are breathing but unconscious. So when someone comes, or if you're by yourself, at this point you're going to call 999. Okay, so if you're in a care home, there should be other people, so you can allocate it to someone else. You need to be very clear of your communication. So you'll say when the person comes in the room to help you, you'll say their name. You'll tell them that they're not breathing or they're not responsive, and you'll tell them to call 999 for the ambulance. Another staff member, when they come into the room, if you ask them to get the emergency equipment, so the defib and the grab bag, for example, ask them to go get it. I'll talk about that in the next slide. And then once you've called 999, you're gonna start the compressions. Now, when you call 999, preferably use a landline, as the ambulance service will get the precise location. If you use a mobile phone, before you tell them the address, they'll just get a triangulated area of where that call is coming from. So preferably use a landline. And in a nursing home, typically you're going to have to dial a number first to get an outside line. So that's usually going to be 9. So it'll be 4 9s in a care home rather than to 3 9s. But just check with your own care home whether it is actually 9 to get an outside line. So once you called 999, you would have also asked someone to get the emergency equipment if you have it in the premises. So the defib is the defibrillator, if you have one, and the grab bag has got other items for like maintaining the airway, oxygen, suctioning the airway, etc. So whatever emergency equipment, you need to get it, and you need to call it simple titles. So grab bag and defib are easy to say in emergencies, but someone should be sent to get these. So once you know that 909 is being called and the emergency defib and grab bag are being retrieved, you then need to start compression. So the person who's come in and found the casualty, they need to start compressions. So you're going to place your hands in the center of the chest. So that means the middle lower half of the chest bone. So the middle of the nipple line, it may be right on a CPR dummy mannequin, but in real life that's not going to be reliable. So you want to just put your hands in the center of the chest, and you're going to give continuous compressions at the rate of between 100 to 120 per minute. So compression only CPR, this is what we're talking about. It's only effective for 5 minutes, but you need to start doing it. and that is going to be continuous. So you're going to continue this until another staff member takes over, and then preferably that should be happening every minute. So one of the senior staff should be in overall control of the situation, hands off, telling people what to do, and they should be swapping whoever's doing the compressions every 1 minute at maximum, because your CPR will degrade with your fatigue. The other time to stop doing the compressions is when the AED, the defib, tells you not to touch the casualty. When the ambulance arrives and they tell you to stop CPR, do not stop when you see them coming in the room. So you listen to what they say, but you carry on when you see them coming into the room. And then the other time to stop is if there's signs of life, which realistically will only occur after the AED is given a shock. So once you start CPR, those are the only times you're going to stop doing it. To have effective compressions, you do need a hard surface. So if they're on a spring mattress, they do need to come to the floor. However, in a care home, that's unlikely they're going to be on a spring mattress. They're either going to be on a foam mattress or on an air mattress. So you can do the compressions on a foam mattress, they'll still be effective. But on an air mattress, you're going to need to pull the CPR pull, which is in the diagram. The yellow and red CPR pull, you need to pull that to let the air out. Or in different types of air mattress, it may be slightly different. So for example, the red nozzle, which you rotate to let the air out, but you need to become familiar with your air mattress in your care home, and they should be clearly like on display outside of the sheet so you can release the air. Now, during CPR, if the casualty does regurgitate their stomach contents, then you can roll them away from you and tip their head back to let the fluid drain. And then once it's come out, you can roll them back onto their back and continue with compressions. When the defibrillator arrives, whoever's brought it should open up the defibrillator lid and follow the visual and voice instructions. So anyone can use an AED. So AED stands for Automated External Defibrillator. We call it defib in emergencies because otherwise automated external defibrillators is a bit of a mouthful. So you want to have very simple communication in emergencies. So we call it defib. So you just open it up and you do what it says. Very simple to use. You do not need to have any training. Anyone can use them. You're never going to shock someone accidentally. It is just not going to do that. Okay. Studies have shown that even 7-year-old children can use them with very limited or no training. The CPR, even if you don't have a defibrillator, the effective and timely CPR can extend the time that the heart can be restarted with a shock. So CPR is very important. So you just when the defibrillator comes, you that's when you tear the clothing off or cut the clothing, and you apply the pads as the defibrillator shows you in the images it will have, at least on the pad packet, if not visual display on the actual defibrillator. You just do what it says. There's a few safety concerns. If there's any GTM patches, remove them from the body. The pacemakers, they'll always be put on the left now, so this may not be relevant anymore, but you just don't want the pad being on the pacemaker because it's metal. You want to remove any jewelry from the casualty's chest, turn off any oxygen. Water, you can remove them from the wet surface, remove them from the metal surface, and just make sure any bystanders or relatives are not going to touch the casualty when the defibrillator says not to touch them. So the most important safety aspect with the use of defibrillator is just not to touch the casualty when the defibrillator says do not touch them. Okay. So that is how to deal with an unconscious casualty who's either breathing or not breathing. So you'll go through the doctor's ABCD in its entirety, and if you can do that rapidly, so within just a few minutes, then you can drastically increase their chances of survival. So we have the concept of the chain of survival. So early access, so calling 999 early, if you do that within less than a minute. Early CPR, so again as quick as possible, but again starting it within a minute of finding the casualty. Early defibrillation, so as soon as possible, but like if the target time can be less than 3 minutes, and again if it could be within a minute of finding the casualty. And then if they get advanced cardiac life support within 20 minutes from the ambulance service, if it could happen that fast, they'd have a very good chance of survival if they don't have comorbidities, etc. So for further information, you can go onto the Resus Council website. So they have all the information, which is based on research, which they update their guidelines every 5 years. So that's what I've based this video upon, but you can look it up to get further information. The next situation to talk about is choking. So choking is an obstruction to an individual's upper airway, usually due to food, which interferes with the maintenance of an airway and breathing. It is potentially life-threatening. So the actions on entering a room where you believe someone is choking, always start with the doctor's ABCD. You do not know what's happened, so you need to first assess for danger, and then you need to see if there's a response. Now, if they're choking, then they're probably either sitting or standing up, and they're probably gripping their throat, and they probably look panicked, and so you can easily tell that they are responsive. So once you've seen they're responsive and you've got some clues that they might be choking, you ask them, are you choking? Now this is important because they're either going to speak to you or they're going to nod their head. If they speak to you, it's not life-threatening. If they nod their head, it potentially is life-threatening. And obviously, if they do nod their head, they are confirming it is choking, because it could also be an anaphylaxis, which is a severe allergy reaction, or it could be asthma. So you need to ascertain that it is choking. The next thing you need to do is to ask them to cough. If the cough is effective, then encourage them to cough and do not touch them. Okay, so coughing will clear the obstruction. And if they can cough effectively, it's not life-threatening. If they cannot cough or the cough is ineffective, then this means it is a life-threatening choke. You then need to shout, send a signal for help, as I've previously mentioned when dealing with an unconscious casualty. You then need to put your gloves on and have a quick look in their mouth to see if you can see an obstruction, such as cling film or plastic apron or gloves. These are sort of things that a service user with dementia in a care home might pick up and then put in their mouth. It could also be like the paper plastic bib could be in their mouth. So you can have a quick look and just from the edge, using a pincer movement with your gloved fingers, just remove the plastic or other objects. I say plastic because that's what it most likely is going to be. Do not put your fingers in deep into the mouth. I'm talking just from the edge of the mouth. So if you put your fingers in, you might make the obstruction worse. You might push it back further, and you may trigger the gag reflex, causing them to vomit or them to bite your fingers. So only from the edge, if you see something, do you remove it. Now, if you can't see the obstruction and remove a pincer movement from the edge of the mouth, then you're going to stand them up, you're going to bend them forwards, and you're going to give them 5 back slaps. And you'll do these individually. So if you do one back slap and it comes out, then you stop. You let them like sit down, rest, or they could even go in the recovery position if appropriate for them. So you don't actually have to do a whole 5. If it doesn't come out with the 5 back slaps, you then do 5 abdominal thrusts. And this is why you have to have practical training, because you have to be shown how to do this. So this is just knowledge that you've been given. So during all the back slaps and abdominal thrusts, you need to observe if the obstruction is dislodged, and that's when you can stop doing the back slaps and abdominal thrusts. But if not, you continue. You do 5 back slaps, you do 5 abdominal thrusts, and you keep going till the obstruction comes out or the victim becomes unconscious. So one cycle of back slaps and abdominal thrusts will be 5 back slaps and 5 abdominal thrusts. Now, after 3 cycles, if the obstruction has not come out, you can call 999 at that point. Okay. The other time you can call 999 is if they collapse unconscious. So either after 3 cycles or when they collapse. Okay. You may also just decide yourself, depending on the situation, to call 999 earlier. Okay. I can't cover all eventualities, so this is some guidelines on how to deal with a situation. Now, if they do become unconscious, they'll fall to the floor. You'll call 999 and you'll start CPR. You'll get the defib, etc., as we've discussed before, for an unconscious casualty who's not breathing. Because you've seen what's happened. You've seen that they've been choking. It's obstructed their airway. If it's a complete obstruction of the airway, they are going to have a cardiac arrest after some time. So you know what's happened. Once they've collapsed, you know that they've had a cardiac arrest. So you straight call 999, straight onto the compression and get the defibrillator. And again, if you want further information, go on the Resus Council website and you'll get the up-to-date guidelines. So this all comes from their recommendations, which all healthcare professionals and lay people should be getting their guidelines from the Resus Council UK. Also talk about casualty positions. Obviously we talked about the recovery position for an unconscious casualty who is breathing, but other positions. So if someone has a breathing difficulty, they're conscious but they've got a breathing difficulty or chest pain, then they want to be sitting up. And a nice saying is, if it's in the chest, sitting is best. So you've got the image there of the lady in a sitting position. Now she's more in like in a W position with the knees up. So that would be a specific sitting up position for someone with sudden severe chest pain. So we're suggesting they may be having a myocardial infarction or possibly angina attack. So you would want them preferentially in the W position, but definitely sat up. You may need to consider the patient's, the casualties, mobility, etc. when you position them. But if they're fully mobile, then you may get them from the chair onto the floor, their back against the wall in a W position. But if their mobility is poor, maybe you'll keep them sitting in the armchair. It's easier to manage them like going forwards. In the bed, you could put them in the W position with the head and the legs up. But for any other breathing problems, you want them sat up. You want their chest up. Another position is if someone's feeling faint, if they've got low blood pressure, they're feeling dizzy, you want to have them flat with their legs raised. So another saying to remember is, feeling frail, raise a tail. And you can see in the diagram the positioning of the casualty. So they're flat on the floor with the legs raised. So that should help their circulation, increase their blood pressure. Another situation, severe hemorrhage, also known as severe bleeding. So when you come into a situation, always start with a doctor's ABCD. Once you know it's safe, you can approach the casualty. If they're shouting, they've got their eyes open and they're sitting or standing, then they are responsive. So you can stop doing the entirety of the doctor's ABCD and you can then directly deal with the bleeding. So once you've done the danger and response, you're going to ask the casualty to sit down and do self-help. So self-help means them putting their hand directly on the wound, putting pressure on it and holding the limb up if it's in the limb. Okay. You can then do your shout, send signal for help. You can put your emergency gloves on, which I advise you keep in your pocket, and you can assist the casualty to apply direct pressure over their hand, which is on their wound, and help them to raise the affected limb. Okay, so you make sure you've got gloves on to do that, because they're bleeding and there's a potential infection risk. When the other staff come, they can get a first aid box, which should be around the building. You can see in the image there the first aid box. And then you want to apply a dressing from the first aid kit directly onto the wound, and then there should be bandage with the dressing, and you should make sure it's secure but not too tight, and then put pressure on it with your gloved hand and continue to hold it up. If it bleeds through that, you'll put a second dressing over that first one and continue to put pressure on it with your hand, holding the limb up. Now, if that still doesn't stop the bleeding, someone else, another member of staff, can put indirect pressure as well. So they'll find a brachial or femoral pulse, for example, and put indirect pressure on that pulse. You also need to consider the risk of hypovolemia, also known as circulatory shock in this situation, and treat if you believe that's present. So if they're feeling dizzy, they become pale, or their skin becomes clammy, you can't palpate the radial pulse, then as well as directly putting pressure on the wound and raising the limb, etc., you'll have them lie down and raise their legs, as I said in the previous slide. You'll decide whether it requires a 999 response, so you'll call 999 as appropriate at the appropriate time that you realise that it is that serious. Do not remove anything that's impaled into the wound, so a knife, glass, a wooden splinter, a nail. You do not pull it out of the wound. Okay, that only gets removed in the hospital. So you can bandage or pad around that with gauze and bandage around the object. So do not pull it out because it's stopping the bleeding. Do not apply a tourniquet. Okay, it just the type of wound that's likely to happen will not require a tourniquet. You could cause a lot more problems by putting a tourniquet on. Do not give them anything to eat or drink. So first aid is a practical topic, so you would need to be shown all of these things that I'm talking about. And last thing to talk about is burns. So again, when you first come in, you're going to check for danger. So again, if you can manage danger, you manage danger. If not, you stand back, you get assistance, you make sure no one goes into that dangerous situation, and someone senior will decide how to deal with that danger. If there's no danger, then you're going to look for a response, and they're probably going to be responsive. So when you're thinking of the danger, because it's a burn, you may need to remove the casualty from danger, from the burning, if there's a fire in the room. You also need to consider stopping the burning process. So if they're actually on fire, you may need to put them out. Let's say someone's done a barbecue in the garden, they need to drop to the floor, roll them around, put blankets or jackets on them to put out the flames, and unless someone's getting a fire extinguisher as well to try and put them out. So that would come under danger. Once you've dealt with the danger and they are clearly responsive, then you want to cool the burnt area under cool running water for at least 20 minutes. Okay, so it used to be 10 minutes, but we're saying 20 minutes now. So whilst you're running cold water on that burn, you're going to remove any rings, watches, other constricting items from the burnt area. So be careful not to remove clothing that may be stuck to the burn. You can cut round the clothing that's stuck, but do not peel burnt clothing off the actual burn. Take care not to overly cool the victim of large burns, so you may need to get a blanket around them. You just want to cool the burnt area. Once you've done 20 minutes of cold running water, you'll cover the burn with clean cling film, like loosely applied, not wrapped around tight like a bandage, like sheets of loose cling film just to protect it from infection. And then you can put like a burns dressing on top of that cling film. So water gel or burn shield dressings are two brands, and they will continue to cool the burn. You could also continue to run cool water over the top of the cling film. And then you could secure that in a sling or very loosely with a conforming bandage. Again, consider shock. You may need to lie them on the floor with their legs raised. Reassure them. Depending on the severity, the registered nurse or in a residential care home, whoever's senior, will have to decide whether to call 999 or whether the casualty can go with an escort in a taxi to A&E or a minor injuries unit, or if it's even very minor, whether the GP could be consulted. But that depends on the severity and your local situation. So do not burst any blisters that are produced by the burn. Do not apply any lotions, creams or sprays. Do not touch the burn. You should have gloves on when you're dealing with it, but do not touch it even if you've got gloves on. Do not apply cotton wool or plasters to the burn. So once you've done the water, you should be putting cling film to cover the burn, and then a special burns dressing like the burn shield or the water gel on top of that cling film. And just for information, burns victims needing hospital treatment will be all children, all full thickness burns, all burns involving the feet, hands, face or genital area, all burns that extend around a limb, all partial thickness burns larger than 1% body surface area. So 1% of body surface area is equivalent to the casualty's palm. All superficial burns larger than 5% body area will need to go to hospital. And if you're at all unsure about the extent or severity of the burn. And there's references.